Hello, everyone, and I'd like to welcome you all to part one of this two-part webinar series on biofeedback and the pertinence of its use in pelvic health. For those of you who are not familiar with the presenter, it is CLAUDIA Brown, physical therapist, rehabilitation scientist, and professor at the Faculty of Medicine at McGill University. When she's not providing basic or master's level education on pelvic health to her students, CLAUDIA lectures internationally on pelvic floor health, rehab, just like today's presentation. She's featured in a variety of scientific articles, television interviews, journal publications, and research projects. CLAUDIA accomplishes all of this while still maintaining a private practice at La Clinique de Physiothérapie Concorde in Laval, as well as Physiothérapie Urosante, a Canadian teaching organization that focuses on issues related to pelvic health. Without any further ado, it's time to let CLAUDIA take over the presentation and go ahead with her discussion on biofeedback and the pertinence of its use in pelvic health.
Well, good morning, everybody, and thank you very much, John, for that introduction, and thank you also to Geva and the rest of the people at Thought Technology for having invited me to speak to you all today on biofeedback. As a pelvic health physiotherapist, I've used biofeedback since the very, very beginning, which is almost 30 years ago, and that was one of the first modalities that I realized was really helpful for patients who have pelvic floor disorders. And so I'm really happy to talk about biofeedback. So most of the time when I'm giving lectures, it's about physiotherapy in general for pelvic health, but this one I'm really focusing on the tool of biofeedback and how it really helps us in our approach to treatment. So I can start right away. So there are learning objectives for these two parts. The first part, I would like to really explain what biofeedback is all about and why it's really useful for pelvic floor muscle training. I'd like to give you a little bit of ideas on how to work it technically, and Geva will be helping us with that to do a practical demonstration. I also like to have you understand really that there are different applications of biofeedback. So we don't only use it for training, but we use it for education. We use it for exercise, prescription, and we use it also for evaluation to a certain extent. That's the part one, which is today. And then there's part two. And by the end of part two, I'd like you to really understand biofeedback with the help of a couple of case histories to see how we can use biofeedback to uptrain the pelvic floor and to downtrain. So depending on your background, you probably know that the pelvic floor can either be really weak, hypotonic, and cause problems with incontinence and prolapse, or the pelvic floor can also be hypertonic or overactive. This is really the term, excess tone or overactivity in the pelvic floor, and this can be a problem as well. So I'd like you to be able to understand how we change our biofeedback approach according to what type of patient that we have. So what is biofeedback? So biofeedback, it's a mind-body technique that enables an individual to gain control over certain physiological functions. We say mind-body because in order for the body to work, the mind has to work as well. And often a lot of the activities that we do are autonomic, of course, but some of our voluntary musculoskeletal activities are also very much, in the background that we don't really realize that they're happening. So, for example, if I want to stand up straight, I just think of standing up straight. I think of the goal. But what I'm actually doing to stand up straight is I'm really contracting my back muscles, contracting my abdominals, and I'm doing a lot of activities that really aim for a goal. So this is when you're doing things in life, you don't realize that when I want to pick up my cup, I have to actually use my biceps, my deltoid, and all of my muscles. We just do it. So what the biofeedback does is it allows you to break up the activities that you would do and to see them and see how you can change, your physiological function. So this works for the musculoskeletal system. So, with striated muscles for voluntary work, but it also works in the autonomic system, as many psychologists will be able to tell you. So with biofeedback, an individual's physiological response is measured, and that measurement is displayed or fed back to the individual. The individual changes their physiological response and immediately sees the effect of this change on the display. So a lot of it is trial and error. We want to see how we can improve our response. So the individual learns how to change their physiological response in order to achieve a desired effect. So I'm just breaking this down now into these four phrases, okay? So the individual's physiological response is measured. So you can measure the physiological response in many ways. And the one that we're concentrating on most, or that we are concentrating on in this lecture, is Emg Electromyographic Biofeedback. and that measures muscle activity. And we can use that for strength training, we can use that for relaxation training, we can use that for motor planning. So anything where the patient has to learn how to control the muscle activity, we can work with EMG. It's also used a galvanic skin response to measure changes in skin conductivity. So when you're stressed, you'll have different autonomic responses, which will result in a change in your skin conductivity. And that is used quite often to control stress response. You can use EEG to measure the brainwave activity, and that can affect mental activity and relaxation. And you can use ECG or BPV to measure heart rate, and you can work on heart rate variability, and you can also work on stress with these. So there's quite a few ways that you can measure this physiological response. So I'm on to the second sentence now. The measurement is displayed or fed back to the individual. So in order to be fed back to the individual, the measurement data has to be taken in, transferred, processed, and displayed. Okay, so there's a whole activity going on within your apparatus that will allow this display of the measurement. And usually the display is audio or visual. So you can just see a little bit of a summary of the types of display you can have. Like you can have a display of heart activity, you can have display of brain activity, you can have display of EMG activity, you can have a skin impedance display, you can have a temperature display, respiration, you can display left side, right side. So there's anything you want to pick up, you can pick it up, have it processed, measured, transferred, processed, and displayed. And then through all of that, the patient sees the display and tries to change what will be measured. So it's the third sentence, individual changes physiological response. Through trial and error, the individual attempts different strategies in order to effect a change in the physiological response, and thereby can determine which strategies work for them and to what extent. For example, the patient might want to be working on relaxation training, so they might try deep breathing, they might try imagery, they might try progressive body part relaxation, and they're trying to decrease the heart rate. And as they see different changes in the display, then they can improve on the strategy. So it's very motivating for them, because something that they would normally not be able to pick up intuitively, they can see on a screen, and then they can actually work on changing that. And then once they've done all of that learning, then they're able to use those same strategies in real life. So if they were able to work on stress response with biofeedback, and they could see that they were changing their display, they realize, okay, for me, deep breathing really seems to work. For me, imagining myself on that beach seems to work. And they can realize what works with them in the training session. And then when they're in real life and they find themselves in the stress response, they'll be able to respond to that. And it's the same thing for pelvic floor. So the patient, normally, if you don't have pelvic floor disorder, you cough, your muscles contract, and you don't leak urine. I mean, this is the way it works, but you don't really think about it. But for patients who've had multiple deliveries, and who have obstetrical trauma, or patients who have hypotonicity, or just a lack of awareness of the pelvic floor musculature, when they cough or sneeze, maybe that physiological response of the pelvic floor muscle contraction doesn't happen. So they have to learn to identify that response and change that response for the desired effect. And so if they learn that looking on a screen, then when they're in real life and they cough, they can remember, okay, this is what I'm supposed to do when I cough. And so it's a really good learning activity. So the biofeedback that we're concentrating on most today is EMG biofeedback. So that's electromyographic biofeedback. So we know through the neurophysiology, we know that the action potentials are produced when we do muscle contraction. The EMG is going to record the changes in this electrical potential that we have at the muscle. And as the patient contracts more, they might be recruiting more muscle fibers, and then there'll be a summation of this activity. So when we look at the biofeedback, the apparatus will monitor and display the activity according to different activities. So what we look at in physiotherapy for pelvic health is we look at the EMG activity at rest. We also look at it during a voluntary muscle contraction, and we want to also see how the EMG activity is able to come back down to neutral. And this is really important in our muscle training. So we want to see how the patient is at rest, how they are when they contract, and we can train for different types of contractions, and how they are when they finish their contraction. So an increase in muscle activity will result in a summation of action potentials and a stronger EMG signal. patients learn to decrease or increase muscle activity according to particular pathology. So for example, if you're working on a patient who has this problem with contracting during a cough or during a sneeze, then they'll be able to increase that activity just prior to their cough. If it's a patient who has a lot of pelvic pain and their pelvic pain is related to excess tension or excess tone or overactivity in the pelvic floor, they can learn to identify the pelvic floor and respond by releasing that activity in order to decrease pain. Normally, when you have pain, what happens is you contract against the pain. And it's a protective mechanism. So if you've hurt your back before, you hurt your back, and then the next day you can't move. Okay, you're completely in spasm, and that's to protect you from moving again and re-injuring yourself. Same thing happens with the pelvic floor. If you have pain, or if you have fear, or if you have an unwanted event that has happened at the pelvic floor, your body will want to protect you against that pain. And very often, patients who have pelvic pain, they'll realize that when I'm in a stressful situation, my pain is increased. And so stress affects the muscle activity. And so they can understand how they can identify the fact that I'm in a stressful situation. I should relax my muscle because maybe I'll have pain afterwards, or maybe the stress is causing the pain. So they can really see the link between the muscle overactivity and the pain. And then in that case with the biofeedback, they can remember having seen on the screen, okay, how do I relax this muscle? And they'll be able to do it in real life setting. So there's different things that you have to know about biofeedback when you're using it. There's different sensors. So you have, for EMG, we have active electrode and a reference electrode. So the active electrodes are placed on the muscle belly. So if you're looking at a biceps muscle, you put them right on the biceps muscle belly. With the pelvic floor, it's a little bit harder because of the way the pelvic floor is configured to put it exactly on the belly, but there are intercavity probes that you can use that will pick up the EMG activity in the area. So this will pick up the activity, which will increase with muscle activity. The reference electrode is really important because what it does is it monitors the baseline activity in the whole treatment setting. And then the signal from the active electrode is gathered with respect to that reference electrode. So the reference is often called a ground electrode, filtering out all the other noise from other muscles, or even from the lights, or even from any other electrical activity in the area. So with that reference electrode, it really gives you that baseline. And so what you're seeing on the screen is really the change from that baseline activity in the whole area and on the person's body. There's different types of electrodes that you can use for biofeedback. You can use inserted electrodes or surface. So inserted electrodes are needle electrodes or fine wire electrodes that go right into the muscle belly. And these are really a lot more accurate. And these are what you would use if you're doing research where you're doing comparative studies. Surface EMG is on the skin surface or intracavity, but it's also on the surface of the muscle, so it's not within the muscle. And so this is what we use generally in biofeedback in the physiotherapy setting, in the treatment setting. So the best way to really understand biofeedback is to demonstrate it. So I would like to ask Geva if he can help us out with this demo that's coming up.
Hi, yeah. Hello, I'm here. I'm gonna make myself presenter so we can see my screen.
Okay, so what we see is that Geva has put the electrodes on his biceps muscle. So with all of this demonstration, he'll be doing biceps muscle contraction. So we know the biceps bends the elbow. So when he bends the elbow, the biceps will work. And he's also put the reference electrode on a bony point. Okay, so the reference electrode usually should be on a bony point so it doesn't pick up extraneous muscle activity. So he's put it on a bony point, and this is when he contracts, we'll see the activity. So let's just have you just relax for a moment. Now, what you see on the bottom of the screen right now is you see a black line, and that black line is picking up the EMG activity. So his resting activity there's always going to be some resting activity. Okay, if there's none, then you're worried. Okay, the patient should have some resting EMG activity in the muscle. So here's his resting activity. Now, Geva, try to just relax a little bit more and see if you can get that. Good. Wow. Very good. He was able to get that down just by relaxing his muscle a little bit more. So sometimes we don't realize that we're in this certain state of tension. And a lot of our muscles, of course, are postural, so they have to be in a certain amount of activity. So now we see that he was able to relax. So let's just say that you think about the traffic you were in this morning or this afternoon, Geva. So try to, if you're a little bit more tense, or if you come in late, or if you're agitated, then your activation state might be higher. So your resting activity might be higher. So you might notice that some of your patients, when they start talking to you about something stressful, automatically, and if you're in the relaxed state, automatically that goes up. So your activation state will affect your tone or your resting activity. Now I'd like you to try, Geva, just to contract the opposite biceps muscle and see if there's any overflow. So the one on the other side. Sometimes what will happen, okay, so we see there's a little bit, yeah, okay, when you relaxed it, you really relaxed both, didn't you? Okay. Sometimes we see that when there's contralateral activity, that there's a bit of an overflow or some sort of postural effect that can affect the muscles. So you have to realize with that is that what you're seeing on the biofeedback, it isn't always a true readout of exactly the muscle activity. So we use it more as a learning activity than anything else. Now I'd like you to contract, okay, keep your biceps relaxed, but just wiggle your fingers around a little bit. Okay, so that didn't really increase the activity. So try to just abduct your arm, which doesn't use biceps really. So just bring your arm out to the side. Yeah. Okay. And now lift your arm above your head. If you can, if the wire's, yeah. Okay, and back down. So we don't know right now. Now, is it this because he's using his biceps to stabilize his arm? Is it because the deltoid is causing some crosstalk or overflow activity in the muscle? We really don't know. So this is why it's really important when we do biofeedback, is to make sure that there's very little activity going on elsewhere. So the patient has to be really relaxed elsewhere, really well supported in order to really get the truest readout as you can of the muscle. Okay, so that's just to give you an idea of the resting state, and just by seeing how the resting state can change, it really can tell you what you have to take into consideration when you're treating your patient. Okay, great. So let's do voluntary muscle activity. So let's do just a bend your arm just like that. Okay, great. And then back down. So we can see when he bends his arm and go back down. Okay, this is the biceps working. So now do the same thing, Geva, but increase intensity. So resist your arm with the other arm in flexion. So bend and resist. Okay, so now we see he's gone off the screen, okay, and then go back down. So how can we fix that? So what we can do is we can change the sensitivity in the machine, and now we can see the real true maximal contraction. Great. And then excellent. Back down. And now try just doing your natural contraction, just bend your arm just naturally and back down. So you see the difference between a natural contraction and a contraction against resistance. Okay, so let's try to see submaximal contraction. So you can see the little numbers on the side. These are in microvolts. So I can see that you're up to, okay, so you can change that. And as you change that, it shows what has to show up on the screen. So for Geva to fill the screen at this point, he has to generate 100 microvolts. Okay, so go back down to, go back up to 300 microvolts in terms of your scaling. Because we know that for your biceps today, okay, because it can change from day to day. And that doesn't necessarily mean the strength has changed. It could be your activation state. It could be how humid it is in the room. There's very many variables. So from one day to the next, you can't say, well, yesterday you contracted at 200, today you have to contract at 250. It doesn't work that way. It's within the same day on the same muscle on the same person. So now we know that his max is about 300. Can you try that again? Do a max resistive contraction. Okay, so he gets right close up to 300. Good. So this would be great for strength training. Okay, and back down. So strength training, I like to do 5 seconds strong contraction and a double the relaxation time, so we get full recovery of the muscle fibers. Now I'd like you to do a submaximal contraction. So are you able to contract, Geva, to just 150 and hold it there? Okay, a little bit more. Good, and hold it, good, hold it, keep on holding it. So now we're working on a submaximal contraction. So in this case, we can actually work on endurance, and we can train the slower twitch muscle fibers to work so that he would have more endurance capacity. Great, and back down. So when I'm working on endurance, we're going to work for a submaximal contraction for a longer period of time. Okay, so let's say now that we want to work on recruitment speed. Okay, so you're able to, you've strengthened, your endurance has improved, but you just can't get that muscle working quickly enough. So let's see if you can do a squeeze relax and see how fast you can do that. So squeeze quick, relax, squeeze quick, relax, squeeze quick, relax, squeeze quick, relax, squeeze quick, relax. Good. Okay, so here's where we teach him to do a quick alternating contraction and relaxation. Okay, so the other thing I'd like to see, Geva, can you put it so that we see a resting line more or less in the middle of the screen? So this would be his resting activity. Okay, there. Okay, we brought it up. Okay, so keep yourself relaxed. Okay, and now we'd like to see what happens after a contraction. Is he able to really recuperate his muscle completely to the resting period? Okay, so let's first see what his rest is. So just relax more. Sometimes you have to wait until he stabilizes his muscle. And yeah, so the signal is pretty well stabilized there. So we see that his relaxation is varying somewhere between 2 and 4 microvolts. Okay, so do a maximal contraction now. So you have to resist with your other arm. That's it, max, 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 max. Okay, and back down. And let's see if you've recuperated. So it took a little while for the muscle to recuperate, and it still hasn't recuperated completely. So you can see that after a maximal contraction, in some cases, that it's hard for them to get all the way down. Okay, so try to relax a bit more. There you go. Take a deep breath in. Breathe out. Relax. Okay, so good. So he's really good at the relaxation part. Okay, so he's able to bring it down. And this is something that you have to work on with your patients. And sometimes it's frustrating because they can't always get it down that quickly. So now we see, okay, this is better now. And now that he's stopped for a while, it's coming down even more. Let's just try just a natural contraction and see if you recuperate to there. Just bend your elbow and back down. Yeah, it's still taking. So, there we go. It's coming down a little bit. Okay, good. So this gives you an idea of how the muscle has to recuperate after the contraction. Okay, super. Okay, so I think that was great to let you know how we work the muscles. There's a couple of things maybe, Geva, you can show us, because we'll do often in pelvic floor physio and also with postural training, you can do 1 or 2 channel displays. So can you show us how you would do that? So you can display, for example, you can put some electrodes on the abdominals and put the other electrodes on the pelvic floor. So.
Yeah, so with the myonics, all I really have to do is just connect the other channel, just connect the other cable, and the second signal will automatically be displayed. Right now, it's not connected to anything, so it's just noise what we're seeing there. And let me zoom out a little bit so we'll see the entire both signals. You'll see we have the black signal, which was my original one. And then, because there's so much noise, it's really up there, the channel B one, but then now you can see it. I zoomed out a lot. So you can see the second channel there in gold. And with the myonics, again, because it's an app on a smart tablet, really all the controls are as simple as you can imagine. You just drag and drop, or as a pinch to zoom to get a clearer view of the entire amplitude of the signal. I can also scale the 2 channels separately. So right now, both channels, as you can see, when I'm moving them, when I'm zooming in and zooming out, they're both zooming in and out at the same rate. But if I deselect this link channel button on the bottom left, I can actually play with the separate scales separately. So I can zoom more into channel A and less into channel B in case we are working with one large muscle, one small muscle, and things like that. Another thing is we can continuously calculate the maximum voluntary contraction. So what we looked at before and said, okay, I could reach 300. I don't have to memorize that. I have a button here saying MVC, and then it will constantly tell me, okay, this is the maximum you got. Right now it's 427 on channel A, and I can always just aspire to reach to that. And if I go higher than that, it will readjust itself, of course. So that's another thing to take into account. There are also different views. So line view is the very classic, easy to understand view that we usually use a lot. But there's also a bar graph view. And again, with the Myonics, because it's an app interface, it's very easy to change between them. It's just a swipe on the screen. So right now I just swiped left on my screen, and now I'm at this bar graph view. There's also an animation view. Animation view, what it does is when I'm in session, when the session will start, as long as I'm in the condition that I set, so above this threshold that is very low right now, as long as I am in that condition, the animation will run. And I will show you this in 1 second. I'm starting the session. As long as I'm under the threshold, it won't run. Once I get above, I don't know, can you see it now? Can you see the animation?
Yeah, now it's working.
We can see it move, yes.
Okay, beautiful. So as long as I'm above this threshold, the animation is running. This is some specific animation of a walk inside a spaceship. There's different animations I can go to. This is travel between the stars. We have things that are more adjusted for kids. So again, if I'm above, it will run. If I'm below, it will pause. Something cool that we can do with the Myonics is go into full screen mode with this. And then when I'm in full screen mode, I don't see my signal. So I don't know where I am, but I do know if I'm succeeding or not because the animation will run. And again, it's running right now. You can see it on your...
Yeah.
Perfect. So as long as I'm in condition, I'm doing good. So I have not what we call knowledge of results. I don't have knowledge of performance. I don't know where my signal is, but I know I'm succeeding or not succeeding. And at some points in the therapy, this is important because we want to move to less feedback and less information. So we make it a little bit more challenging. So that's the full screen view. If I stop the session or it reaches the time that we set for it, I get to the review screen. I can look at all the different statistics for the session, and I can zoom in, look at the session itself, and generate a report and save it under the patient file for later viewing. I think, Claudia, we wanted to show also the pattern view.
Yes, the template, yeah.
So yeah, we used to, some people call it templates, patterns, but that's a different, separate type of view. That if I swipe to that, okay, so here, instead of having a threshold to be above or be below, I am instructed to try to remain within the gray line. And this is a much more difficult task. I can change, of course, the sensitivity to make it easier or more difficult, but the task stays the same. Try to stay within that gray line. If I focus, I can do it, but that took me a lot of practice. When I started playing with this, I wasn't even able to do that. So that's a challenging thing. And of course, we have different patterns you can select from and create your own pattern as well.
Super. Thanks very much, Geva. I think that covered everything we wanted to see. Okay. All right. So we saw resting activity during relaxed state, increased activation, contralateral musculature, and adjacent musculature. And now we also saw Emg activity during these activities, natural increase, submaximal, and then we looked at post-contractile relaxation, and then we looked at all of these parameters. So, you can set it up so it has work and rest cycles, so the patient knows when to work and when to rest, and the rest of it, there's a goal line, so you have to attain a certain goal, as you saw. And one other thing, we might not have mentioned, was the activity flagging. So as the patient is doing an activity and you say, okay, cough, and you want to see what happens with the pelvic floor, you can actually flag that time so that when you're looking at your report later, you can see, what what happened, when they coughed. So in pelvic health, it's an important element in our toolkit. We use it in treating urinary disorders, anorectal dysfunction, sexual dysfunction, and pelvic pain. We use it for men, for women, for children. It's part of a multimodal approach. So of course, biofeedback on its own to treat pelvic floor disorders is not enough, but it's a really interesting adjunct to our treatment. So with our treatment in physiotherapy for pelvic health, we use education, exercise, manual techniques, sometimes electrical stimulation, sometimes manometric techniques, sometimes insertion techniques for patients with sexual pain. So we use a lot of different techniques, and biofeedback is part of our toolkit. And with the biofeedback, we train proprioception, motor planning, contractility, relaxation, and control. So the typical type of electrodes we would use would be, you can use surface electrodes on the perineum. So on either side of the central perineal tendon, you can put 2 surface electrodes, and they look like this. They're sticky electrodes, or they look like this. We also can use these same electrodes on the abdominals. If you want to pick up abdominal activity. So you can use the abdominals in training synergies, but also to see in decreasing abdominal activity if they have what's called an inversion of the perineal command, where they're pushing instead of contracting. So we can teach them to decrease abdominal activity as well. And intracavity, we have the anal probe, and we also have the vaginal probe. So there's a vaginal probe like this, which is, I like to use this one for patients who have pain because it's easier to insert and to remove. And also I like to use this one if I'm doing electrical stimulation, because I use the same probe to stim with, and I can really access the Alcock's canal where the pudendal nerve is most prominent. This one is actually fun to use if you want to work in standing, because as the patient is standing, it won't slide out, and so they can do different activities with the pelvic floor in standing and see if they're working their pelvic floor. You have to be really careful if you do that type of training, though, because everything else works when you're in standing. Your glutes work, your adductors work, your abdominals work, everything's working. All your hip rotators work, and you know that the obturator internus is, the muscle that the pelvic floor is exactly inserted onto. So you're going to get a lot of crosstalk. So in standing, you can, even if you have this vaginal probe, you cannot be certain that it's the patient's pelvic floor that's contracting. So it's fun to use and it's motivating, but the problem is if they're using their glutes instead and they're getting crosstalk, they'll think they're using their pelvic floor. So I find you have to be really careful working in standing, because as we mentioned before, in order to be sure you're getting the true muscle, all the other muscles basically have to be relaxed to get your true, or the closest as you can to the true muscle activity. So when this is a picture of the, superior view of the pelvic floor. So when you have the, so this would be the vagina here, and the anus would be just below the rectum here. You're not actually on the muscle bulk, you're very, very close to it, but you're not actually on the belly like Eva was with his biceps. So when you're inserting, say this would be the side view, you're inserting past the pelvic floor, but the pelvic floor does have, the side parts that are not completely in contact with your probe. So you just have to realize that, look, here is the obturator internus. So if that's generating Emg activity, there will be crosstalk into the pelvic floor. And you can demonstrate that if you have a patient do external rotation against resistance with the probe inside, the trace will go up and it looks like a pelvic floor contraction. So you really have to know what you're doing. You can't just insert the probe and let the patient work on their program on their own until you're sure that they're able to really localize the pelvic floor muscle. So the abdominals, where do we put it on the abdominals? We tend to put the electrodes all on one side, so you're getting the same muscle belly. So, this is, typically your placements for different abdominal muscles. The transverse muscle is deep underneath all of this. So if the transverse works, all of these will pick it up, and I'm sure you're getting crosstalk. So I really don't really believe that you can really localize specifically unless you're doing needle or wire electrode. Otherwise you get so much crosstalk, and depending on skin impedance, it can change things. So as long as you realize the limitations, it's a really good way to work, and not having the patient say, okay, you're up to 50 microvolts and we need you to be up to 60 today, because that's not the way it works. And you have to, even when the patient says, oh, I'm going higher today, well, yeah, well, that's great. It means you are, recruiting activity, but it doesn't necessarily mean that it's stronger. So important to consider, wait a minute, the surface EMG is a raw measure of electrical activity. It does not represent strength, but increase in motor recruitment and firing rate. It's affected by the electrical conductivity of the skin and all the tissue between the skin and the muscle. So we're talking about, blood flow, we're talking about adipose tissue, we're talking about all that tissue, according to how conductive it is, will change your readout on the EMG. So you cannot compare signals between patients, nor between different muscles on the same patient, nor from one day to the next. And crosstalk is something that you have to really consider. The surface sensors, if you're doing surface EMG, it'll pick up any electrical recording, which might not just include target muscle, but also signals from other muscles, if those signals reach that surface electrode. So EMG biofeedback in pelvic health is particularly useful because pelvic floor musculature is hidden. So patients can't see their contractions. So when they see it on the screen, that's great. We also use, different type of biofeedback. You can use a mirror, and a mirror is a visual biofeedback, and they can see the movement of their muscle. But seeing it on the screen really makes the training a lot more fun for them and for the therapist. Trains neural pathways, improves muscle control, and promotes increased recruitment of muscle fibers, and it helps you to plan your exercise program, monitors synergies and compensations, and as I said, makes it a lot more fun to work with. So those are the references. So on the video, we'll be showing how to test the electrodes, how to do the reflex contraction, how to eliminate compensations, how to work on all of these other different things. Okay, good. So I'll just put the video on, and I'll stay after for questions in case any of you are interested or have anything to ask. Okay, so here you see the biofeedback video, and you can see at the bottom of it that there's actually two traces. So we have abdominal trace and we have pelvic floor. The abdominal is gold, pelvic floor is black. So here I had the patient cough. So cough, and you can see that both electrodes worked, and that's normal because when you cough, you should have a pelvic floor contraction and you should use the abdominals. So I had her cough again, and you can see with a larger cough, you can see that the abdominals did work and so did the pelvic floor. So this is good news for me. I know that she has a good reflex contraction when she coughs, if it's not a question of crosstalk, of course. And I also know that the electrodes are working. So I know the abdominal electrodes are working and the pelvic floor electrodes are working. So the idea of that is to really see if I have a good electrode contraction, a good contraction. Okay, and then the next thing I'm going to have, so that was just coughing, and now I'm going to have her do a pelvic floor contraction. So you'll say, squeeze the pelvic floor, contract, okay, contract the pelvic floor, contract. So she's contracting the pelvic floor, but she's also using her abdominals a lot. We know the transverse abdominis works in synergy with the pelvic floor, but we should not be seeing that much abdominal muscle activity. So I'm going to have her squeeze, but don't try so hard. If you don't try as hard, then the abdominals won't kick in as much. So squeeze again, great. So you can see this time she squeezed. She still had transverse abdominis contraction, but not as much. So we're going to do that again. And so each time I ask her to squeeze, just try to, if they're trying too hard, use different images, like just try to bring in the skin, just try a light contraction, just squeeze the soft tissue. They don't have to do a full strong movement. So as you're training them, they can start to really recognize the pelvic floor contraction, and she's squeezing much better now. So she's doing a pelvic floor contraction with a little bit of abdominal activity, which for me is just fine. And so that way I can train eliminating the compensations. But you'll see later how I train using the abdominal muscles. Okay, so in this case, I want to eliminate the abdominal or decrease the abdominal musculature as much as I can. Okay, so the next screen, okay, you can see here the work and rest periods. So you can see that they're a different color, and on top you can see work, rest. So the patient knows when it's time to work and when it's time to rest. Now, what I've done just for the rest of the demo is just to remove the abdominal cable, just so you can concentrate on what's happening with the pelvic floor. So here we're doing 5-second squeeze and a 10-second rest. And so this would be strength training. So when you're doing strength training, you get them to squeeze maximally 5 seconds, and then relax for 10. It's really hard to do a maximal contraction of the pelvic floor for much longer than 5 seconds. So I think a 5-second training is really ideal. And as she, as she gets better at it, her contraction will improve. And this can happen very quickly within the same session. And then you can also see that it's easier for her from one session to the next, it's easier for her to kick in on the muscle and to really understand what's going on. So here it's, again, I'm working on strength. So I'm doing a 5-second contraction and I'm doing a 10-second relaxation. And you can see I had put a goal line there. And with the goal line, she was able to really see, okay, that's how hard, that's how much I should contract. And it really is a lot more motivating because she can get over the goal line. And as Geva showed you, you can make different animations happen when they attain the goal line. So that's interesting. And when it's all over, I can do just get a summary, and I can see that before I put the goal line in, that she was contracting, and then the contraction got better and better, and especially when I put in the goal line and told her, okay, squeeze up to here, squeeze up to here. And so in that case, she was able to really work on really perfecting that contraction. So the patient might say, okay, now I'm able to squeeze before I cough and I don't leak, but when I sneeze, I don't have time to squeeze. So this is where you work on recruitment speed. So squeeze, let go, squeeze, let go, squeeze, let go. So in this case, she learns how to find that muscle quickly, relax it quickly. So really it's the finding for somebody who has trouble. She'll say, well, I don't have time to contract my muscle when I sneeze. Well, if you have time to put your arm in front of your mouth, you have time to contract your pelvic floor. So let's train that. So squeeze, let go, squeeze, let go, squeeze, let go. And then that way she trains her she trains the speed of contraction. So that works out pretty well. And then, okay, so that would be on recruitment speed. So then you have other patients who have difficulty relaxing the pelvic floor. And this is what we saw already with Geva, where we had him just relax and relax more. So this patient, I put her on, oh wait, oh no, sorry, that's not right. Okay, so this is somebody who is trying to do the speed contraction, but she's not able to relax in between. She squeezes and she relaxes not completely. So in this case, I have her squeeze and relax, but try to relax more in between each contraction, get it all the way down. So you get them to squeeze and relax more, concentrate more, relax the muscle all the way down. Good, squeeze. And no, I'd like you to squeeze only once you've relaxed, only once you've relaxed. No, try again, relax all the way down, all the way down. Let it go, drop it. Don't even think of squeezing anymore, just relax. Don't think of squeezing. Okay, perfect. Okay, now we're going to try that again. And then instead of saying, okay, I'd like you to do 10 in 10 seconds, I'd like you to do, say, 6 in 10 seconds. And then she'll learn how to get that muscle down a lot more easily. So this is really good in training relaxation, is to see how, and so it's a good outcome measure as well, because you can see that before she was only able to do 3 and get all the way to the bottom. Now she can do 6, you know. So this is a good way of working on the relaxation. Okay. All right, and then after that, what we'd like to work on, okay, so here I'm doing another one there. Okay, have her relax completely in between, have her relax completely in between, again, and again. Okay, so then we're going to work on somebody who'll say, well, you know, I can't hold contraction for very long, so we need to work on slow twitch muscle fibers. So this is where we'll work on endurance. So I think we did that actually with Geva. So you squeeze to what's your maximum. Once you find what your maximum is, then you take your goal line and you bring your goal line down to halfway, and you want to go right just above that goal line the next time that you squeeze. Okay, so we're going to work on your slow twitch muscle fibers. Okay, hold that. Let's see if you can hold it for a long period of time. And this is really important to work on, because part of the pelvic floor is fast twitch, part of it is slow twitch. And you know, the pelvic floor really is a postural muscle. And you can see that with somebody who has poor posture, who will be, you know, sitting crooked. And then when you get them to train, they'll be able to straighten up and contract their back muscles. And eventually that's normal. So the muscles start to fire naturally on their own as postural muscles. And this is what we're looking for with our patients who have low tone or who have low strength in the pelvic floor. We're trying to work on endurance so that they can bring the muscle in and hold that muscle for longer and longer periods of time. In this one, what I do is I'll have her contract. And when I see she's starting to waver, I'll say, okay, that is your exercise prescription. Okay, looks like you held, what is it, 5, 10, 15, 10, 12 seconds there. So at home, what you're going to do is do half level contractions for 12 seconds. And then that way, you know, I'd like you to build up eventually. And then eventually my goal is that she can hold a half level contraction, submaximal, for actually 60 seconds. So then after that, you can work on gradual relaxation. Gradual contraction, gradual relaxation. So squeeze just a little bit, squeeze a little bit more, squeeze, 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 and now go down. Now, when you say to go down, sometimes they drop. So you just say, let go, let go, let go. Or you can say contract, but less, contract, but less. And what's the value of doing this? The value of doing this is to teach them how to understand a different level of contraction to see, so they can in real life see when they're really too contracted or really too relaxed, and see where their muscle is. And the other goal is to, as you contract a muscle gradually, then you don't lose muscle fiber, you recruit more muscle fibers. So the muscle fibers have more of a chance to come in because you're doing a gradual contraction and a gradual relaxation. So this is really good for working in strength training, but I also use it for relaxation so that they can identify when their muscle is in a relaxed state. Okay, the next one's the podium, which is a little bit too long. Okay, so the podium is very similar, where they're going to one level and then they'll, okay, sorry, that's another gradual contraction, gradual relaxation. Okay. Okay, the next one you'll see is a podium. It's not much longer video, so just bear with me. I know we're over time a little bit. Okay, so this one will be, that's gradual, so you work on that with the patient, and then you can work on. Podium is very similar, but it's more in terms of exercising a certain amount of control in the muscle. So here we're going to have her contract to one level, and then she will contract a little bit stronger. You go up stronger, contract to the next level, and then hold that level, and then contract to the next level. And so this way she's able to find fibers, find more fibers. So it's almost like an inner range work, but it also is a very, you know, important work to do in terms of motor planning and motor control. Okay, so that would be that. And the next one is, okay, so what I like to work on, once they've gained their contraction of the pelvic floor, I like to work on synergies. And I like to work on synergies in the supine position at first, and then after they can work on them in standing. So what I'm getting the patient to do, you can see that I put the abdominal electrode back on. So the abdominal electrode's back on. I've had her do a pelvic floor contraction, and now she's done the pelvic floor contraction, and now I've asked her to lift her legs or abdominals work. And now I'm going to resist that hip flexion. So I'm using my arm holding her leg, and I say, hold your pelvic floor, and now your abdominals are working even more as stabilizers. So we have the abdominals working and the pelvic floor. And so I'm going to resist that movement of your leg, and your abdominals are really working. Keep your pelvic floor going with the abdominals. Keep on going, keep on going. And now when you let your leg down, what I'd like you to be able to do is I'd like you to be able to keep your pelvic floor contracted. So let your leg down, keep your pelvic floor up. Okay, this is long. You would never have a patient contract for that long, but this is just for demo. And now she was able to relax her abdominals, but she kept her pelvic floor contracted, and now her pelvic floor is relaxing completely. Okay, now you can let your pelvic floor down. So this is really good for control and working on synergies, working on the muscles working together in synergy. Okay, so the next one is relaxation. And so if the patient is, okay, she comes in an activated, high activated state, her muscles are really tight, so you can have her just, okay, I'd like you to just relax. Okay, this is resting activity. It's a little bit jumpy, so let's try to calm your muscle down. So I'd like you to take a deep breath in, breathe out. Try to imagine your pelvis is melting into the bed. Relax. Relax your pelvic floor. Good. Keep on relaxing. Then you'll find what are the cues that work for this patient. And then those cues she can use. So sometimes the cue is have your pelvis melt into the bed. Sometimes the cue is just think of nothing. Sometimes it's breathing. Sometimes it's mindfulness. You know, it all depends on what works for that patient. So you use all the different strategies that you can to get them to relax the muscle as much as possible. And hopefully, over time, it starts to come down. Sometimes this is frustrating, as I mentioned before, for some patients. So you have a machine that has really good sensitivity that you can really see the small changes, that really helps, because sometimes the changes aren't visible enough and they try to relax, and the more they try to relax, the more stress they get, and it starts going up. So when that happens, I usually say, okay, we won't continue that training for today. Let's save that one for another day when it's a little bit easier, more easy for you to relax. So, what you're hoping to get is get a relaxation all the way down. But this is actually quite optimistic. It's not something that we get with a patient automatically in one setting, unless you've worked on that a lot already. And then, they could find that, use the strategies that they've already found. Okay, so the last thing is, yeah, it's the template. So here's where you can see how you can Geva showed you how that works. So you get the patient to contract, hold it in there, try to follow the template, and keep your contraction within. And you can set this so you can according to their sensitivity. So you have to make it so that it's attainable. Otherwise, it'll be really frustrating. So you have to set your you have to have done a few contractions first, see what their maximum is, what how many microvolts they can generate at a pretty good contraction. Then you set your sensitivity for your template in that sense. And this is fun. I mean, I use this for children, but I also use this a lot for the adults. And especially when you're doing strength training is, can be pretty boring and pretty long. So if you get them to do strength and motor planning and everything else and work on different things like, speed, endurance, and, strength, you work on all of these parameters, and this really makes it a lot more interesting for the patient to be able to do that. Okay, great. So I think that's it for that. I don't know how to turn this off now. I think I just go to the next slide. Perfect. Okay.
One person was asking if you recommend this type of therapy, this type of treatment for at-home use or for clinical or both. What is your stance on that?
That's a really good question. I really like, in the clinical setting, because we're doing a lot of education, we're doing a lot of other things. I really like to do the biofeedback as part of the whole package. And I'm hoping that what they learn in biofeedback, they're able to carry over at home. I would say that since COVID, it's a little bit different because they can't come into the clinic as much to do the biofeedback. So in that case, the home units would work really, really well. We're doing a lot of tele-rehab now. And so if the patient could learn how to use that on their own, and we could just, give them, updates and, work on their program, that could work really well. So my personal use is really in the clinical setting, because often they'll say, oh, I need a machine like this at home. And then I usually say, well, actually, no, we're hoping that at home, it'll be automatic and you'll learn how to do this. So this is for you to learn what to do at home. It's really hard to, like for pelvic floor exercises, to actually do them. And if you have to set yourself up and insert a probe and have that time, then you might not do them as often as if you can just do them in the bus. You can do your pelvic floor contractions when you're lifting up your baby. You can make it a lot more functional. So I find that, in that case, doing functional activities works better. But there are the, specific patients that really want to train more. In that case, I think that could work quite well.
Great, says thanks. Another question is holding urine the same muscle group?
Yes. Okay. That's a good question. So in order to holding urine, you mean like if you have the urge to go, is that what that would mean? So if somebody has the urge to go, that means they're holding their urine. Okay. So the muscle group to prevent you from having that urge is the pelvic floor. What it does is actually squeezes the urethra, and by squeezing the urethra, urine won't come out. So the urge will go away. But the idea is that squeezing the urethra, there's actually a reflex that has been documented, and they've done studies on the cat, and they found that there is actually a reflex that when you squeeze the pelvic floor, you inhibit the bladder contraction. So the urge to go is usually the bladder contracting. And so when that bladder contracts, then your brain gets the message that there's an urge to go. So in order to prevent yourself from going, you can squeeze the pelvic floor, and it sends a message to the bladder to calm down and to comply and to hold more urine. So yes, that muscle does help holding in. But what also helps a lot is the cortex. The cortex inhibits the bladder. So the cortex will be able to tell the bladder it's not time to go. So we get the patients to use the cortex and the pelvic floor in order to hold urine. I hope that answered that question.
Yes, says got it, thanks. Great. So we have one last question just came in. It might be a little long for right now, but it's the question is how you set up the training for patients after prostate surgery because of prostate cancer, which are incontinent in relaxation.
Mm-hmm. Yeah, so prostate, there's a lot of incontinence that we see post-prostatectomy when the prostate's removed part of the internal sphincter. So that you have internal sphincter, which is autonomic, and you have an external sphincter, which is a striated muscle. So the autonomic sphincter is basically destroyed during, radical prostatectomy. So you have to make up with that, make up for the internal sphincter with more work with the external sphincter. So in that case, it's really training the patient to use that muscle. The problem is that they'll leak a lot more because there's no the autonomic control is really decreased. So you have to work a lot on their timing. You have to get them to accumulate urine in the bladder because it ends up just dripping out. So you have to get them to lie down a couple of times a day to accumulate some urine in the bladder and get the bladder used to holding urine again. So it's quite complicated. It's not just a matter of pelvic floor training. It's a lot of routine and habit training, a lot of behavioral type of therapy that you would have to do in that case. And a lot of these men who've had prostatectomy, they might have an overactive bladder. So some of them, the bladder's been working really hard to get the urine out, and suddenly the prostate's removed, and now the bladder is still working hard, and so it's just leaking even more. So these patients might need medication to calm the bladder down as well. So it's really a multimodal, multidisciplinary interdisciplinary approach for prostatectomy. But yes, pelvic floor training really does help because you want them to find that muscle and use it when they need to use it. So we get them to document, okay, every time I get out of the car is when I leak, okay, or it's always in the afternoon. So then you'll say, okay, what you have to do is before you get out of the car, squeeze your pelvic floor, get up, go to the washroom. And then if it's in the afternoon, then what you're going to have to do is find some strategy in the afternoon to use your pelvic floor more often, sit down. When they sit down, they get a compression, they won't leak as much. They don't leak as much lying down. So we get them to sit and lie several times during the day so the bladder can control the urine. Yeah, so it's quite a complicated approach, but pelvic floor physio and biofeedback do help a lot for them. And the men, they really like to know, I shouldn't say it that way, it's not to be politically correct, but I have noticed that they want to know exactly how many exercises they should do. And they're, some of them are very Cartesian about it. So to see it on the screen is really motivating for them.
Great, thanks. There's a couple more questions if you still have time.
Yeah, I have another couple of minutes, yeah.
Okay, so the first one was, do you sometimes use pressure sensor in pelvic floor treatments?
Yes, sometimes I'll use pressure sensor. I mean, the pressure sensor is interesting because it measures pressure as opposed to measuring the electromyographic activity. So you're seeing how much actual closure you're actually getting around the probe. So it's a different measure. So it's very interesting. The problem with the pressure probe, especially if you're using the anal pressure probe, is that whenever the patient contracts, it tends to move. And there's a huge difference when the pressure probe is just one, like 2 millimeters difference. You can see a big difference. So sometimes they get discouraged because the probe, it's not that they're squeezing less, it's that the probe is moved, and you don't get that change as much with EMG. So that's one of the reasons why I don't use it in that case. And for the women, or for when I'm doing the vaginal probe, in that case, pressure probe is interesting, but you always have to make sure it's not sliding in and out. So you have to be holding it, and the advantage is that with the pressure probe, you can actually see that squeeze pressure. So that's interesting. The other thing is, if I'm planning to do electrical stimulation anyway, then I might as well use the EMG probe because it does both stim and EMG.
Very true. I would like to mention that the Myonics has also a connection to pressure sensing as well. So you can also connect. So the Myonics has 2 channels of biofeedback, and it does both EMG and pressure with a separate additional purchase that you add to it. And then another question was, someone is interested in the online course you mentioned and how she can find that.
Okay, so my colleague and I, Marie-Josée Lord, and we have a company called Physio Euro Santé. I think actually I have the website here. Do you still see my screen or not?
Yes.
Okay, so Eurosanté, that's the website. That's we have on that website, we have a list of all the courses we give for pelvic health. So you can see them there.
That's great, and I think.
And there are many levels of courses too, because pelvic health involves a lot of different things. So the first course to get involved in pelvic health as a physiotherapist is to do a basic course on female urinary incontinence, where you learn all about the muscles of the pelvic floor and how to palpate and everything else. And that's a basic course. And that's right now it's a 4-day course, but it will be longer probably next year. And then we have courses on female pelvic pain, then on male pelvic pain, and on pediatric disorders, on anal rectal disorders as well, and on chronic pelvic pain. So it's really a series of courses to really become expert in pelvic health. But the way in is really with female urinary incontinence, because it's a very large population and there's a lot of research on that approach.
Excellent. Thank you so much. We have a lot of thank you messages. People are saying it was great and interesting, and thank you very, very much, Claudia, for this wonderful presentation. And we hope to see you all also next week with us.
Okay. Yeah, I'll be here. So hope to see everybody else. Okay, thanks. Bye for now.
Thank you. Bye.